we are the Group C5, and for our RLE topic, we will be discussing the different assessment types, which are neurovascular assessment, pupillary assessment, Glasgow Coma Scale, and the cranial nerve assessment. So for the table of contents, we will be discussing each topic or assessment, and we will be giving its objectives as we discuss the topic for your guidance. So to begin with, we have the neurovascular assessment.
First, we have neurovascular assessment to be reported by me, Jonadine Pereira, and Charles Kenneth Buslon. So first, we have the objectives. After 1 hour of lecture discussion, the Level 3 students will be able to define the following: neurovascular assessment, compartment syndrome, paresthesia. They will also be able to identify the purpose of neurovascular assessment and discuss the neurovascular assessment as to its indications, parameters and method of exam and interpretation of results, guidelines, and normal and abnormal findings. So first, we have the definition of terms. So we have neurovascular assessment. So neurovascular assessment is an assessment of the extremities performed to evaluate sensory and motor function, or the neuro, and peripheral circulation, or the vascular. So the components of the neurovascular assessment includes pulses, capillary refill, skin color, temperature, sensation, and motor function. Next, we have compartment syndrome. So this is the increase in pressure of a closed muscle compartment that causes muscle and nerve ischemia. So this usually occurs in the legs, feet, arms, or hands. Next, we have paresthesia. So it is a burning or prickling sensation. So this is most common when there is sustained pressure on a nerve and experienced as temporary paresthesia, or what we call pins and needles. But what is the purpose of neurovascular assessment? So it is an important component of the physical examination and is especially critical for patients at risk for neurovascular compromise. It is to recognize early neurovascular deterioration and to prevent permanent damage to the limb. Indications of neurovascular assessment include musculoskeletal trauma to the extremities. So this is to detect secondary ischemic injury to the extremities and implement appropriate and timely treatment of any neuromuscular defects. Next, we have post-operative. So following invasive procedures, a thorough neurovascular assessment should be conducted regularly to ensure or demonstrate return of function. Application of plaster cast. So by assessing for changes in circulation and oxygenation in a casted or an immobilized arm or leg, you can detect threats to neurologic function. Application of traction. Traction limits movement and reduces the fracture to help decrease pain, spasms, and swelling. It aims to restore and maintain straight alignment and length of bone following fractures. Burn patients. Clients with burn injuries are at increased risk of circulatory compromise due to significant fluid loss and fluid shifts. Circumferential burns should be identified, monitored for circulatory compromise. Signs of infection in the limb. A close assessment is to be done to prevent the spread of the infection and complications related to sensory and motor function of the limb, as well as its peripheral circulation. Parameters and method of exam and interpretation of results. For pulses, you should assess upper extremity peripheral pulses, the brachial, radial, and ulnar, and lower extremity peripheral pulses, the femoral, popliteal, posterior tibialis, and dorsalis pedis, bilaterally. Be sure to assess for the presence of pulses distal to any injury. Use a 4-point scale, 0 as absent and 4 as strong or bounding, noting also if the pulse is weak, diminished, or absent. Use a marker to indicate a pulse palpation site that is difficult to locate. This can help others with their assessment and provide consistency. A manual Doppler scan should be utilized if a pulse palpation site is challenging to find or if the pulse is weak. If palpable pulses are not accessible due to casting, assess all other parameters. Document if a change in the pulse is detected and notify the appropriate healthcare provider. For capillary refill, you should assess this by pressing on the nail beds to evaluate the peripheral vascular perfusion. Note how long it takes for the distal capillary bed to regain its color after pressure has been applied to cause blanching. Capillary refill time of 2 seconds or less is normal for an adult. Prolonged capillary refill time can indicate abnormal perfusion. Capillary refill time can be affected by age, temperature, ambient light, and pressure application. For skin color, compare the color of the skin bilaterally. Consider the patient's usual skin tone and any skin conditions when performing this assessment. Cyanosis can be present differently in different skin tones. Pallor or cyanosis may indicate inadequate arterial supply. Dusky cyanotic mottled or purple-black coloration may indicate inadequate venous return. Shiny and pale skin suggesting pressure in the affected area may be a sign of compartment syndrome and requires immediate intervention to prevent vascular compromise that can result in muscle and nerve ischemia. For temperature, use the back of your hands to assess skin temperature bilaterally. Skin should be warm to touch. Cool skin may indicate inadequate arterial supply, while warmth may indicate inadequate venous return. For motor function, assess range of motion and strength. The patient's ability to perform specific movements is a key indicator of motor function of specific nerves. Loss of motor function is often a late sign of neurovascular compromise. Thus, frequent assessment and careful attention is required to detect these subtle changes in the patient. For sensation, ask the patient about changes in sensation such as tingling, numbness, pressure, or burning. A pressure sensory exam often consists of assessing light touch with a cotton swab and assessing temperature discrimination with warmth and cold stimuli. Pinprick sensation can be tested using the sharp end of a disposable safety pin. If indicated, consider using the 2-point discrimination test. Complaints of numbness or tingling in an extremity should be investigated immediately with the assessment proximal and distal to the site of injury or surgery. Nerve involvement, compromised blood flow, or the use of ice can alter a patient's sensory function. For pain, complications can be prevented when pain is identified and treated early. Pain can be caused by sensory nerve damage and/or diminished blood flow. Use a pain assessment tool to assess severity of pain. Note the location, severity, and areas of radiating pain. In sedated patients or those who can't verbalize information, be aware of nonverbal pain cues including grimacing, guarding, tachycardia, and hypotension. Lastly, we have edema. It can result from musculoskeletal injury, can contribute to vascular compromise, and can cause damage to muscle and nerve tissue. Pre-existing disease processes like heart failure, cirrhosis, or kidney disease can place a patient at increased risk for edema-related complication. Elevating the limb no higher than heart level can help decrease edema.
My name is Kenneth Albislan, and for this topic, I will be discussing the guidelines in performing neurovascular assessment. So let's begin. First guideline, inform the client that the assessment is non-invasive as it does not involve any invasive procedure. Slight discomfort may be felt also while performing the assessment, especially when assessing pain. Second, bilateral assessment of findings is important. It does not mean that when the left leg does not have edema, automatically the right leg does not have edema as well. Also, note subtle changes as it can have significant implications. Third, include all extremities in documentation and notify the healthcare provider of any changes of each extremity. Fourth, if palpable pulses are not accessible due to the presence of casting, assess all other parameters. Fifth, use marker to indicate pulse palpation so that the gathered results will provide consistency. Sixth, note skin color bilaterally. Consider also the client's skin tone and skin condition. 7. Assess temperature using the back of the hands bilaterally and use also thermometer. 8. Assess sensation from the proximal to the distal point from the site of injury if not precluded by a cast or sprint. Ninth, to assess pain, use a pain assessment tool and note location, severity, and areas of radiating pain. Be aware also of non-verbal cues for clients who are sedated and clients who can't verbalize. Next guideline, when assessing peripheral circulation, the nurse must check peripheral pulses as well as the capillary refill response within 3 seconds. Check also edema and the color and temperature of the skin. Next, while assessing motion, the nurse should note any weakness or paralysis of the injured body part. And the last guideline, in assessing sensation, the nurse monitors for paresthesia or the absence of feeling in the affected extremity, which could indicate nerve damage. So now that you know the guidelines in performing neurovascular assessment, I will now be teaching you the normal and abnormal findings in the conduct of the neurovascular assessment. So on the first column, we have the parameters. The second column, we have the normal findings. And the third column, we have the abnormal findings. So let's begin. For pulse, the normal finding is strong and present. For the abnormal finding, it is absent or diminished. When pulse is absent or diminished, it could only mean that there is a compromised blood flow into the tissues. For the second parameter, we have pain. For the normal finding, it is absent. For the abnormal finding, pain is being felt that is a sensation of constant burning pain that is present even in passive motion. So pain is a very good indicator for an impending compartment syndrome, and take note that this isn't relieved by the intake of analgesia. So for the third parameter, we have capillary refill time. For the normal finding, the nail bed gets back in color 2 seconds or less. For the abnormal finding, it takes longer than 2 seconds for the nail bed to gain back its color. So capillary refill time is a very good indicator if blood flow to the extremity is being compromised. So for the fourth parameter, we have pallor or color. So for the normal finding, the pallor or color should be pink and it's warm. For the abnormal finding, the pallor or the color of the skin appears to be pallor, dusky, cyanotic, mottled, purple-black, shiny, and pale. So pallor is a very good indicator if the extremities are being perfused with blood. So for the next parameter, we have temperature. So if for temperature, the skin must be warm to touch or the temperature is between 36.5 degrees Celsius to 37.5 degrees Celsius. For the abnormal finding, it is cool or the skin feels cool or it is greater than 37.5 degrees Celsius or less than 36.5 degrees Celsius. So temperature is a very good indicator for blood flow. So if it is cool, it could mean that there might be a compromised blood flow. For the next parameter, we have paresthesia. For the normal finding, the client is responsive. For the abnormal finding, the client reports feeling of numbness, tingling, pressure, or burning. For paresthesia, it could mean that there might be a sensation issue, and this is a sign for compartment syndrome as well. So for the second to the last parameter, we have paralysis or motor. For the normal finding, client can perform motor function, and for the abnormal finding, the client has loss of motor function. So paralysis is a very good indicator of nerve damage, especially if the client has already a loss of motor function. For the last parameter, we have edema. For the normal finding, it is not present or it has 1+ grading in which there is no clinical significance. For the abnormal finding, we have pitting or a noticeable pit or a grade of 2+, 3+, or 4+. So edema, if there is a presence, it could indicate that there is swelling. At this point, I will be showcasing to you on how to assess the sensation and motor function of the different nerves of the body. We have radial nerve, median nerve, ulnar nerve, peroneal nerve, and tibial nerve. So for the normal finding of the sensation and motor function of these nerves, the client would not report any pain upon movement of the hand or feet depending on which nerve is being assessed. For the abnormal finding, the client will be reporting decreased sensation or loss of sensation, dysesthesia, numbness, tingling, or a feeling of pins and needles that are poking the nerve upon assessment. So here is a picture on how to assess the sensation and motor function of the radial nerve, median nerve, ulnar nerve. And for the next slide, we have the sensation and motor function assessment for the peroneal nerve and tibial nerve. Nursing responsibilities before, during, and after the conduct of your neurovascular assessment. So before, first, explain the purpose and procedure to the client. This will entail a way to gain compliance from the client. Second, ascertain that the client has given consent to conduct assessment. If not, the client will not be compliant while you are doing the assessment. Third, gather all materials and equipment needed. This is necessary to save time and energy. Fourth, perform medical hand washing so that we couldn't spread pathogens or microorganisms to the client. Fifth, bring all materials and equipment ready for the conduct of your neurovascular assessment. During neurovascular assessment, first, assess pulses bilaterally. Use a marker to indicate pulse palpation site so that there will be a consistent data gathered. Second, note time for capillary bed to regain color. Third, compare skin color bilaterally. Fourth, use the back of the hands, assess skin temperature bilaterally. Fifth, assess light touch with cotton swab. Assess temperature discrimination with warm and cold stimuli. Sixth, take note of client's complaints of numbness or tingling. Seventh, take note of loss of motor function and subtle changes. Eighth, take note of pain, location, severity, and areas of radiating pain. Ninth, assess edema and take note of the edema score. Nursing responsibility after neurovascular assessment. So first, place client back into comfortable position. Second, perform medical hand washing. And third, document accurately the assessment findings all throughout the assessment. Let's now move on to the next topic, which is pupillary assessment. So for the objective of this topic, we have, after 1 hour of lecture discussion, the level 3 students will be able to first define the following terms. We have direct light reflex, consensual light reflex, and anisocoria. Second, discuss briefly the physiology of pupillary reactions. Third, present the purpose of pupillary assessment. Fourth, explain pupillary assessment as to its indications, guidelines, normal and abnormal finding. Discussion of pupillary assessment by discussing the definition of terms. So first term, we have direct light reflex. So it is a reflex that occurs when the eye that is exposed to light constricts. It is a constriction in response to ipsilateral light stimulation. So direct light reflex is a response or the change in pupil size in the eye to which the light is directed. So, example, if the light is shown in the right eye, the right pupil constricts. So, as you could see here in the picture, on the second picture, normal light response, the light is shown on the left eye of the client, which causes it to constrict. So, second term, we have consensual light reflex. It is also known as indirect light reflex. It is a reflex that occurs when exposure to light in one eye results in constriction of the pupil in the opposite eye. It is a constriction in response to illumination of the contralateral eye. So as you could see here in picture B, that the right eye is shown with a light which causes it to constrict. So it is a direct light reflex. But when the right eye is shown with light, it causes the right eye to constrict as well as the left eye to constrict, then it is now called as the consensual light reflex. So that is the difference between direct and consensual light reflex. Consensual light reflex causes a constriction in both eyes even if light is only shown onto one eye. So next term is anisocoria. So anisocoria is a common condition characterized by unequal pupil sizes of both eyes. So as you could see here, a picture of a girl in which the right eye seems dilated and the left eye seems constricted. So to some people, it might be a normal condition for them or a normal characteristic for them. Pupillary reflex. As what we could see here in the picture, it is important to know that behind a normal pupillary constriction is a balance between the sympathetic and parasympathetic nervous system. So what we could see here is that constriction is caused by parasympathetic innervation, while dilation is caused by sympathetic innervation. The pathway and how pupillary constriction occurs. So, the optic nerve fibers acts as afferents, which pass to both pretectal nuclei crossing into posterior commissure. The pretectal nuclei project to the Edinger-Westphal nucleus, from which parasympathetic efferents transverse the oculomotor nerves to ciliary ganglia, where postganglionic fibers in short ciliary nerves innervate the sphincter pupillae muscles, causing the pupils to constrict. Dilation has a different pathway compared to pupillary constriction. Dilation is controlled by the dilator pupillae in contrast to the iris sphincter muscle for pupillary constriction. Sympathetic innervation begins at the cortex with the first synapse at the ciliospinal center. Postsynaptic neurons travel down all the way through the brainstem and finally exit through the cervical sympathetic chain and the superior cervical ganglion. They synapse at the superior cervical ganglion, where third-order neurons travel through the carotid plexus and then reaching hypothalamus, which enters into the orbit through the first division of the trigeminal nerve, causing the iris dilator muscle to dilate. It is important to note that pupillary constriction is caused by parasympathetic innervation, and the muscle mostly responsible for it is the iris sphincter muscle. In contrast, pupillary dilation is generally caused by sympathetic innervation, and it is mostly controlled by the dilator pupillae or the iris dilator muscle.
Hello everyone, I am Anna Dominic Gison and I will be discussing the purpose of pupillary assessment, the indications, guidelines, and the normal and abnormal findings. In a neurological evaluation, pupil assessment is an important aspect of it, and the sole purpose of a pupillary assessment is because improvements in the pupil scale, equality, and reactivity may provide vital diagnostic information to a critically ill patient. Also, examination of the pupils and its reflexes are crucial in obtaining an accurate diagnosis of an ophthalmological problem and many other systemic conditions. For the indications of pupillary assessment, the first is conjunctivitis. We need to measure the level of inflammation and its effect on the accessory eye structures. With this, patients with conjunctivitis needs to have a pupillary assessment. The second is cataract. In patients with cataract, the pupil frequently fails to dilate. In patients about to undergo cataract surgery, this is particularly necessary as the pupils may have to be dilated completely to expose the lens. Third is the use of illicit or unlawful drugs. Pupillary assessment is conducted in patients who have used illicit drugs because they frequently impair the capacity of the eye to dilate or constrict. The fourth one is suspected brain injury. It is important to determine whether brain damage has occurred after head trauma, and this can be achieved by pupil assessment. The fifth one is optic neuritis. It is an inflammation of the optic nerve, so the level of inflammation must be determined by pupillary examination. The next one, intracranial hemorrhage. Serious bleeding within the cranium can lead to a buildup of pressure on the brain that can lead to brain injury. As a result, in order to assess brain injury, the pupillary assessment should be performed. The next is glaucoma. In glaucoma patients, an irregular pupillary light reflex is usually observed, and these variations can be used to separate glaucomatous eyes from unaffected eyes. The next, brain tumor. A regular standardized eye test involving pupillary assessment may often diagnose eye problems that signify a brain tumor before any symptoms become evident. The next is stroke. After a stroke, pressure that builds within your brain can affect the muscles in the iris that usually make the pupils open and close. In the dilated state, one or both of your pupils may become fixed and cannot respond to light. The next is adystonic pupil. It is an anisocoria where the abnormal pupil is larger and does not constrict to light but slowly constrict to accommodation. The next one is third nerve palsy. Confirming a third nerve palsy with pupillary assessment can either be partial or complete. A complete third nerve palsy is evidenced by a fully dilated pupil, fully abducted down and out eye, complete ptosis, and no constriction to either light or accommodation. The last is Horner syndrome. Horner syndrome is a rare condition characterized by meiosis, constriction of the pupil, ptosis, drooping of the upper eyelid, and anhidrosis, absence of sweating of the face. This can be confirmed with a pupillary assessment. Guidelines for the pupillary assessment. First, check the size, shape, equality, and position of the pupils and the response to bright light. Next, pupillary assessment should be made in a dimly lit room since pupils are induced into a semi-dilated state that is conducive to examining. Next, patients should be encouraged to fixate visually on a distant object. This is in order to observe other reactions or conditions in conjunction with the pupillary light reflex, such as anisocoria. Next, we need to try not to startle or touch patients with our hands or instruments, since psychosensory stimulation induces mydriasis, hippus, and relatively hyperactive pupils. Next, to assess pupillary size in a darkened room, we need to illuminate the face from below. Next, we need to slowly move the light up to the patient's eye level and check the pupillary response to the bright light on each side several times. Lastly, we need to look at the amount of pupillary constriction that occurs when the patient is forced to focus on a near object. The normal and abnormal findings of pupillary assessment. For the first assessment procedure, inspect the iris and the pupil. For the normal findings, typically, the iris is round, flat, and evenly colored. Centered in the iris is the pupil, round with a regular border. Normally, pupils are equal in size, 3 to 5 mm. In 20% of clients, a pupil size inequality of less than 0.5 mm occurs. This condition is normal, referred to as anisocoria. For the abnormal findings, the inequality of size is abnormal if the difference in pupil size changes throughout pupillary response tests. The next assessment procedure is to test pupillary reaction to light. For the normal findings, constriction is the normal direct pupillary response. For the abnormal findings, when light directed at the blind eye results in no response in either pupil, monocular blindness can be detected. Both pupils constrict when light is directed into the unaffected eye. The next assessment procedure is to assess consensual response. For the normal findings, constriction is the normal consensual pupillary response. For the abnormal findings, pupils do not respond to direct and consensual pupil testing at all. For the last assessment procedure is to test accommodation of pupils. For the normal findings, constriction of the pupils and convergence of the eyes when focusing on a near object is the normal pupillary response. This is the accommodation and convergence. For the abnormal findings, pupils do not constrict and eyes do not converge. Next is the nursing responsibilities before the assessment. The first is explain the procedure to the patient. Next, conduct pre-procedure tests to determine whether there are any pre-existing irregularities with the eyes of the patient or variables that may affect the outcome of the pupillary assessment. The next is to gather materials. These includes a pen torch and a patient's observation chart. In some situations, a neurological assessment chart is also included. Next, we need to wash and dry our hands. This is to adhere to the principle of microbiology. For the nursing responsibilities during the assessment, we need to dim the overhead light source. Dim light will facilitate a clearer view of the pupils and their response to light. Next is to position properly in front of the patient. This is to adhere to the principle of proper body mechanics. Next, look into each of the patient's eyes, examining the size of the pupils. Note the size of each pupil. If available, use the scale printed on the neurological assessment chart as a comparison. This is an example of a scale that can be sometimes found in a neurological assessment chart. Next, compare the sizes of the pupils. Also note the shape of each pupil. Also, compare the shapes of the pupils. Then, shift the torchlight towards the pupil from the side of the head and notice any change in the size of the pupil and the reaction speed. Next, avoid shining light in the other eye. Observe whether the opposite pupil also reacts. Then, repeat the above procedure in the opposite eye. For the nursing responsibilities after the procedure, we need to document the findings of the pupillary assessment. If necessary, inform the charge nurse or physician of any changes or abnormalities that may have occurred. Lastly, we need to do aftercare.
Hi everyone, good day. I am JV Ignacio A. Singson, and this part, together with Ms. Tangal, we will be reporting about the Glasgow Coma Scale. So, for the objective of this for the Glasgow Coma Scale, after 1 hour of varied classroom activities, the level 3 students will be able to CLO number 1, define the following terms: 1.1, the aphasia; 1.2, the apraxia; 1.3 is the cerebrate; 1.4 is the corticate. For CLO number 2, present the purpose of Glasgow Coma Scale assessment. For CLO number 3, describe the different levels of consciousness. For the CLO number 4 is discuss the Glasgow Coma Scale assessment as to its 4.1 indication, 4.2 limitation, 4.3 normal and abnormal findings, 4.3.1 the adult Glasgow Coma Scale, 4.3.2 the pediatric Glasgow Coma Scale, and lastly the CLO number 5 is examine the nursing responsibilities before, during, and after using the GCS tool. So, okay, for the first CLO, the CLO number 1 is the definition of term. So before we go in details for the different terms, and before we go in details with our discussion, let us first define what is Glasgow Coma Scale. So, Glasgow Coma Scale is the most common scoring system used to describe the level of consciousness in a person following a traumatic brain injury. So basically, it is used to help gauge the severity of an acute brain injury. The test is simple, it is reliable and correlates well with outcome following a severe brain injury. So the first term, we have the aphasia. Aphasia is a neurologic disorder caused by the damage to the portion of the brain that are responsible for language production or processing. Aphasia is not a disease but a symptom to brain damage. Although it is primarily seen in individuals who have suffered stroke, aphasia can also result from brain tumor, infection, inflammation, head injury, or dementia that affect the language-associated region of the brain. Next term, we have apraxia. Apraxia is a neurologic disorder characterized by the inability to perform language movement or command even though the command is understood and there is willingness to perform the movement. The both desire and the capacity to move are present, but the person simply cannot execute the act. So apraxia is a result from dysfunction of the cerebral hemisphere of the brain, specifically the parietal lobe, and can arise from many diseases or damage to the brain. So for the differentiation of aphasia versus apraxia, as we see that the apraxia, the part of the brain that is affected is the language production or processing center of the brain, while the apraxia, it is the result from the dysfunction of the cerebral hemisphere of the brain, specifically the parietal lobe. Next terms, we have the cerebrate and the corticate. So, cerebrate and the corticate posturing are both considered pathological posturing responses to usual stimuli from external or internal source. Both involve stereotypical movement of the trunk and extremity and are typically indicative of significant brain or spinal injury. So, let us first define what is the cerebrate. The cerebrate, this is a type of normal and extending posturing result from the damage to the upper brainstem of the patient. So remember, the cerebrate is the upper brainstem has damage. The patient will have a visible adduction and extension of the arms and pronation of the hands, and the fingers will be flexed along with the extended legs and plantar flexion of the feet. So I have this mnemonic for us to better understand what is decerebrate. So this mnemonic, kindly see the word decerebrate. So in the word decerebrate, look at all the E's in the word. There are a lot of them, so remember the word extended. In patient who has a decerebrate posturing, the patient's arm are going to be extended rather than flexed. So I'll be showing you a picture of a patient who has a decerebrate posturing. So here is it. So in the decerebrate rigidity or the abnormal extensor response, the patient's upper arm are flexed tight to the side with elbows, wrists, and fingers flexed. The legs are extended and internally rotated. The feet are plantar flexed. This posture, it is caused by a lesion in the diencephalon, midbrain, or pons, although severe metabolic disorder such as hypoxia or hypoglycemia may also produce this kind of posturing. So next, we have the decorticate posturing. So the decorticate posturing, this is a type of abnormal posturing, is often an indication of certain type of brain and spinal cord injury, or specifically, this indicates a damage to the cerebral hemisphere of the patient. So remember, decorticate the cerebral hemisphere of the patient. So the posture is stiff, with legs held out, straight, fist clenched, and arms bent to hold the hands on the chest. So for us to easily understand decorticate posturing, I have also this mnemonic. So remember the letter COR in the word decorticate. This implies to the word core. The patient who has a decorticate posturing will bring their arms to the core of the body or to the middle of the body. So I'll also show you a picture of a patient who has a decorticate posturing. So here's it. So decorticate rigidity or the abnormal flexor response, the patient's jaw are clenched and the neck is extended. The arms are adducted and stiffly extended at the elbow with forearms pronated, wrist and fingers flexed. The legs are stiffly extended at the knees with the feet plantar flexed. This posture may occur spontaneously only in response to the external stimuli such as light, noise, or pain. This posture implies a destructive lesion to the corticospinal tract with or very near the cerebral hemisphere. When unilateral, this is the posture of a chronic spastic hemiplegia. So that's it for the CLO number 1. Next, for the CLO number 2, the purpose of the Glasgow Coma Scale assessment. So the purpose of the Glasgow Coma Scale or the GCS is used to objectively describe the extent of impaired consciousness in all types of acute, medical, and trauma patients, specifically following a brain injury. Next is GCS allows evaluation of a patient's neurological status over time. Next is to assess the patient's response to tactile stimuli if unconscious, pupillary response to light, and corneal and gag reflex and motor function. So next, let's move on to the CLO number 3, the different levels of consciousness. So we have 8 levels of consciousness. These are the first, full consciousness. The definition of this is the patient who is full and conscious is awake and alert. The patient is also oriented to time and place. The patient's behavior is also appropriate for his age. So next type we have confused. So in this type of consciousness, the patient has the inability to think rapidly and clearly. There is impaired judgment and decision making brought by the patient. Next type we have the disorientation. So this is the beginning of the loss of consciousness. There is disorientation in place, impaired memory, and confusion regarding time and place. Next, we have lethargy. The patient in this level of consciousness, the patient is drowsy. The patient also sleeps a lot but is easily aroused with minimal stimuli such as voice and also respond. The patient may not be oriented in time, place, or person. The patient will also exhibit a sluggishness of speech. Next type or the level of consciousness is we have obtundation. So the definition of this is the patient is difficult to arouse but aroused by repeated stimuli but not pain. Example of stimuli is shaking and will then respond to question or commands. The patient also cannot make a complete sentence in this level of consciousness. Next, number 6, we have stupor. So the patient has no verbal response in this type of consciousness. This is a condition of deep sleep or unresponsiveness of the patient. The patient can only be aroused or caused to make a motor or verbal response by a vigorous and repeated external stimuli, specifically painful stimulation. The patient may moan and respond to pain by moving its extremities. Next, we have coma. So, in this type of level of consciousness, the patient has no motor or verbal response to the external environment or to any stimuli, even deep pain or suctioning. There's also no evidence of awareness. There is different types of coma. First is the mild coma. It is a brief loss of consciousness and normal imaging. For moderate coma, it is a brief loss of consciousness and abnormal imaging. For severe coma, its duration is longer than 24 hours with abnormal imaging. For deep coma, comatose for a very long period of time can be in months or in years. And lastly, the last level of consciousness, we have the persistent vegetative state or the PVS. This defined as the permanently lost function of the cerebral cortex. So now let's move on for the CLO number 4, describe Glasgow Coma Scale Assessment as to its 4.1 indication. So GCS is used with patient with traumatic brain injury. It is also used to assess for brain injury. It also assesses the level of consciousness of the patient. It is also indicated for acute medical and trauma patient. So GCS is also indicated for pre-verbal children with blunt head trauma, for stroke patients, for patients with history of seizure, and patients who have been corrected for hypovolemia, hypoxia, and drug abuse. So that's it for my part. Again, this is JV Ignacio Asingson. Thank you and God bless.
Hello, good day. My name is Hilary Martha C. Tangal, and I will be talking about the continuation of our objective, which is the limitations of the Glasgow Coma Scale. So we have factors that can lead to inaccurate score of the GCS. We have drug use, alcohol intoxication, shock, and low blood oxygen. Why is this? This is because it can alter a patient's level of consciousness. The Glasgow Coma Scale is also grossly predictive but cannot accurately predict outcomes in individual patients. This is because the GCS is used to only measure a person's LOC or level of consciousness. It cannot predict the outcome of the patient. The GCS can be subject to language barriers. Method of interaction with the patient is important for them to follow instructions during the GCS assessment, which makes choice of language a very important thing. If language barriers exist, it may lead to inaccurate scoring of the GCS. Next, we have the GCS does not check if the person can learn and remember things. A person's ability to form new memories is important in helping healthcare providers predict his recovery after a TBI or a traumatic brain injury. So as we all know, GCS only can measure the level of consciousness of a person. Lastly, we have the GCS cannot be used to assess a verbal score in intubated or aphakic clients. However, it is still the most widely used scoring system for intensive care unit or ICU comatose patients. So if you need to assess the GCS of a client who is intubated, you have to indicate that the client is intubated. Next, we have the normal and abnormal findings of the adult Glasgow Coma Scale and the pediatric Glasgow Coma Scale. First, we have the adult Glasgow Coma Scale. So, the Glasgow Coma Scale is a clinical scale used to reliably measure a person's level of consciousness after a brain injury. So, it assesses a person based on their ability to perform eye movements, speak, and move their body. So here we have a picture of a Glasgow Coma Scale, which is divided into 3 categories. As I mentioned earlier, we have the eye, the motor, and the verbal. So for the eye category, we have 4 as the highest score and 1 as the lowest score. For motor, we have 6 as the highest score and 1 as the lowest score. And for verbal, we have 5 as the highest score and 1 as the lowest score. So for our first category, which is the eye, so when a patient opens eyes spontaneously, we give them a score of 4, which is the highest score. So if the patient doesn't open their eyes spontaneously, you need to speak to the patient. If the patient's eyes open in response to the sound of your voice, then you score them 3. If the patient doesn't open their eyes in response to your sound, you need to move on to assessing eye opening to pain. There are different ways of assessing response to pain, but the most common is the applying pressure to one of the patient's fingertips. If the patient's eyes opens in response to the stimulus you've given, they score 2 points. And if they do not open their eyes to the painful stimulus you've given, they'll be given a score of 1, which is the lowest score. So we move on to the next category, which is the motor response. So if you ask the patient to lift their arm and make or make a fist, and if they are able to follow this command correctly, they would score a 6 points in the assessment. So if not, we move on to see if the patient identifies localized pain, like when you give them a painful stimulus and they try to reach to the site where you put in the painful stimulus. If the patient is able to do this, you give them a score of 5. However, if they flex or withdraws to the painful stimulus, we give them a 4. And if the patient assumes a decorticate position, which was shown earlier in the discussion, we give them a 3. And if the patient assumes a decerebrate position, we give them a 2. And if there's no response from the patient, we give them the lowest score of 1. Next, we have the next category, which is the verbal response. This initially involves trying to engage the patient in conversation and assess if they are oriented. So if the patient is able to answer your questions appropriately, the assessment of verbal response would be complete with a score of 5 points. If the patient is able to reply but their responses doesn't seem quite right, this would be classified as confused conversation and they would be scored 4 points. If the patient responds with random words, they are completely unrelated to the questions, then this would be classified as inappropriate words and would be given a score of 3. If the patient is making sounds like groaning, moaning, or screaming rather than speaking words, this would be classified as incomprehensible and would be scored 2 points. And if the patient does not respond, we give them a score of 1. After all these, you add all the scores up, and the highest score would be 15, and the lowest score is a 3. If you get a score between 13 to 15, that would mean a mild head injury. If you score 9 to 12, moderate head injury, and if you had a score of 8 or less, it would indicate a severe head injury. So as we see below, it's an example of how a Glasgow Coma Scale score would be written as. It would be read as the GCS of the patient is E4, V4, M5 with a total of 13, indicating that the patient has a mild brain injury. So normal findings of the GCS would be a score of 15, which indicates an optimal level of consciousness. Under abnormal findings, we have a GCS score of less than 15, indicates some impairment in the level of consciousness. So a score of 8 and below generally is accepted as a coma, and a score of 3 indicates deep coma or a brain dead state. The pediatric Glasgow Coma Scale. A pediatric version of the GCS recognizes that expected verbal and motor responses must be related to the child's age. The pediatric coma scale does not assess verbal responses as such, but records smiling, crying, and interaction. It is important to note that the pediatric Glasgow Coma Scale is inappropriate for children below the age of 6 months. It is indicated for infants, children from an age of 6 months to 5 years old. So here we have a picture of the pediatric Glasgow Coma Scale. It has same categories as the adult Glasgow Coma Scale, which is the eyes, the motor, and the verbal responses. However, as you see here in the verbal responses, it is related to the child's age. So we have for the greater than 2 years old, and we have for the less than 2 years old. So as you can see in the less than 2 years old, it doesn't necessarily follow auditory or a conversation, but more on the cues of a child. So we have for 5, the child will smile, listen, and follows. 4, cries consolable. For 3, inappropriate persistent cry. 2, agitated, restless, and 1 for no response. So it also has the same score interpretation as the adult Glasgow Coma Scale. Also, same rules apply in the normal findings and abnormal findings for the pediatric Glasgow Coma Scale. So 15, a score of 15 indicates optimal level of consciousness, and a score less than 15 indicates some impairment in the level of consciousness. Score of 8 or below is generally accepted as a coma, and a score of 3 indicates deep coma or a brain dead state. For nursing responsibilities before the Glasgow Coma assessment, we have read detailed patient history, explain the procedure to the patient or loved one, ensure a quiet environment so that we'll have a proper assessment, and gather materials if needed, and wash and dry hands. For during, the nurse should make sure that instructions of each category are given and heard properly by the client, observe client's reaction and cues properly, and score client according to the response given. After the assessment, it is important to document the findings of the assessment, and if necessary, inform the nurse in charge or the physician about the score of the assessment, and lastly, do aftercare. And now we move over to the cranial nerve assessment. So for our objective, after 1 hour of class discussion, the level 3 students will be able to first define the following terms: anosmia, hyposmia, agnosia, stereognosis, ptosis, nystagmus. Second, identify the purpose of cranial nerve assessment. Third, discuss cranial nerve assessment as to its indication, contraindications, and normal and abnormal findings. So we have the definition of terms. So first we have anosmia. Anosmia is also known as smell blindness. This is the loss of the ability to detect one or more smells, or in short, it is the inability to smell. On the other hand, we have hyposmia, which is a reduced ability to smell and to detect odors. In other words, it is diminished sense of smell. This is different from anosmia because anosmia is the inability to smell. However, hyposmia is the diminished sense to smell. So nausea is the loss of the ability to recognize objects, faces, voices, or places. So this is caused usually by the damage to the parietal, temporal, or the occipital lobe of the brain. Stereognosis is the ability to identify an object by touch rather than sight. It is the ability to perceive and recognize the form of an object in the absence of visual and auditory information by using tactile information to provide cues. To test stereognosis, you ask the patient to close your eyes and identify the object you place in their hand. You can either place a coin or a key and repeat this with the other hand using a different object. Ptosis, which is the drooping of eyelids. Third, cranial nerve palsies can result in drooping of eyelid, or as we call ptosis. Lastly, nystagmus, which is a rhythmic oscillation of the eyes, or a vision condition in which the eyes make repetitive and uncontrolled movements. Nystagmus is most commonly caused by a neurological problem that is present at birth or develops in early childhood. Acquired nystagmus can occur in diseases such as stroke, multiple sclerosis, or trauma.
Good day everyone, I'm Patricia Micaela Villalbistondo. I'm going to discuss the objectives 2 and 3. Purpose of cranial nerve assessment. Purpose of cranial nerve assessment. It provides insightful and vital information about the patient's nervous system. Cranial nerve exam allows directed tests of forebrain and brainstem structures. Provides insight into damage to specific regions of the brain stem and may uncover deficits in adjacent region. A systematic approach which allows a complete and thorough examination in a timely manner. It allows the clinician to define patient's problem and along with the result of the physical examination, which assists in formulating an etiologic or pathologic diagnosis in most cases. Here are some of the indications of the cranial nerve assessment. First, altered movement patterns, involuntary, unsteady, or slow movements, tremors or twitching of the facial muscle. Second, change in balance and coordination, clumsiness or unsteady or altered gait, especially changes resulting in falls and injury. Third, altered speech patterns, which also may lead to difficulty of swallowing. Fourth, muscle wasting. Fifth, change in behavior, or difficulty in concentrating or thinking, confusion or lethargy, including changes expressed by friends and family members. Fifth, change in sense of hearing. And lastly, vertigo, fainting, and dizziness. So to continue, let's discuss the contraindication of the cranial nerve assessment. First, alteration in level consciousness. Cranial nerve assessment needs a participation of the client in which if the client is unconscious, she or he can able to do the assessment. Second, immunocompromised patients that has difficulty in doing some parts of the assessment. Let's discuss the normal and abnormal findings of the cranial nerve assessment. Cranial nerve 1. Normal findings. The client can identify the scent that was given by the examiner. It might be a coffee or an alcohol. Abnormal findings. Neurogenic anosmia indicates olfactory tract lesion or tumor. Nasal sinus problems. Smell should always be evaluated after head trauma because the olfactory nerve may be sheared off as it penetrates the cribriform plate. Basal meningiomas can also cause neurologic loss of smell by invading the cribriform plate. Cranial nerve 2. Client has 20/20 vision on both eyes. Clients read the print at 14 inches with full visual fields. Abnormal findings. Has difficulty reading the Snellen chart. Visual field smaller than the normal. Has possible glaucoma. One half vision in one or both eyes has possible nerve damage. Difficulty reading newsprint unless due to aging process. For cranial nerve 3, 4, and 6. Normal findings. Eyelids covers about 2 mm of the iris. Eyes move in a smooth, coordinated motion in all directions. Bilateral or limited pupils constrict simultaneously, and the pupil opposite of the one illuminated constricts simultaneously. For abnormal findings, pulses, abnormal eye movement, nystagmus. Abnormal findings present as the conjugate gaze or double vision. The involvement of the third cranial nerve by compression leads to dilated pupil, ptosis, and eyes looking outward and downward. Lateral rectus palsy is due to the involvement of the sixth cranial nerve. It can be also localizing sign in increased intracranial pressure. Cranial nerve 5. Normal findings. Temporal masseter muscles contract bilaterally. Identify sharp and dull stimuli and light touch to the forehead, cheeks, and chin. Eyelids blink bilaterally. For the abnormal findings, increased contraction in one of the both sides, asymmetric strength in moving the jaw, pain occurs in clenching of the teeth. A corneal reflex is usually performed in a comatose patient to assess the brainstem function. An absence in a awake patient may point to a localized vision affecting either the trigeminal nerve or the facial nerve or both. Cranial nerve 7 or the facial nerve. The normal findings: the client smiles, wrinkles forehead, shows teeth, purses lips, and raises eyebrows and closes eyes. Against resistance. Movements are symmetric. Identifies correct behaviors. Hears whispered words from 1 to 2 feet. For the abnormal findings, inability to close eyes, raises forehead along with the paralysis of the face on the affected side. Inability to identify correct flavor on the anterior two-thirds of the tongue. The location of the weakness in a facial muscles can differentiate between peripheral or central involvement. A weakness with a movement of the entire right side of the face is indicative of either a peripheral lesion or damage to the facial nucleus on the ipsilateral side, like a Bell's palsy. A weakness of the lower half of the face with sparring of the forehead is suggestive of a lesion above and a contralateral to the facial nerve. This is because the forehead has innervation from both the left and the right side of the motor cortex. Damage to the facial nerve can be present with loss of taste to the anterior two-thirds of the tongue. Cranial nerve 8 or the vestibulocochlear nerve. In the normal findings, in Weber test, the vibration heard equally well in both ears. In Wien test, the air conduction is greater than the bone conduction. In the abnormal findings, if a hearing deficit is established during a Weber-Arrin test, can differentiate a sensorineural from conductive hearing loss. A conductive hearing loss will show up bone conduction greater than air conduction. In patients with sensorineural hearing loss, air conduction will be greater than the bone conduction but for a shorter duration when compared to a normal subject. A conductive hearing loss will lateralize the sound to the abnormal ear, while a sensorineural hearing loss will lateralize to the normal ear. For cranial nerve 9 and 10, for the normal finding, uvula and soft palate rise bilaterally and systematically on phonation. Gag reflex is intact. Client swallows without difficulty. And for the abnormal findings, soft palate does not rise with the bilateral lesions of the cranial nerve 10 and absent of a gag reflex. A unilateral lesion to the glossopharyngeal nerve near its exit from the brainstem, damaging all of its fibers, will result in damage to the SVA fibers, relying taste sensation, and will cause ipsilateral loss of taste sensation from the posterior one-third of the tongue. Damage to the GVA parasymptomatic fibers will cause a reduction in salivary secretion of the parotid gland, and damage to the GVA fibers will result into diminished visceral sensation from the pharyngeal mucous membrane, loss of the gag reflex due to the damage of the afferent limb of the reflex arc, and loss of carotid sinus reflex. 7 or the spinal accessory nerve. For the normal findings, symmetric strong contraction of the trapezius muscle. Strong contraction of the sternocleidomastoid muscle on the side opposite to the turned face. For the abnormal findings, asymmetric muscle contraction or drooping of the shoulder. A unilateral lesion confined to the spinal sensory nucleus or the nerve proximal to its muscular distribution results in ipsilateral paralysis and a subsequent atrophy of the sternocleidomastoid and upper part of the trapezius muscle. An individual with such lesion is unable to turn his head away from the lesion. Normally, unilateral contraction of the sternocleidomastoid muscle draws the mastoid process inferiorly, bending head sideways, which is accompanied by an upward turning of the chin towards the opposite side. If the upper part of the trapezius is paralyzed, the upper border of the scapula is rotated laterally and inferiorly with its inferior angle opposite towards the spine. This results in slight drooping of the ipsilateral shoulder, accompanied by weakening of the shoulder, the hypoglossal nerve. For the normal findings, tongue movement is symmetrical and smooth, and bilateral strength is apparent. For the abnormal findings, fasciculation and atrophy of the tongue. A unilateral lesion of the hypoglossal nerve will cause the tongue to deviate towards the side of the lesion or the impaired side. A lesion in the hypoglossal nerve results in a paralysis and a subsequent atrophy of the ipsilateral tongue musculature. Hemiparalysis of the tongue causes shrinkling of the dorsal surface of the tongue, ipsilateral to the lesion. Normally, the simultaneous contraction of the paired genioglossi muscle causes the tongue to protrude straight forward. During the examination of the patient, it is important to remember that a unilateral lesion of the hypoglossal nerve will cause the tongue to deviate towards the side of the lesion or the impaired side, since the functional genioglossi on the intact side is unopposed by the paralysis in active genioglossi on the lesion side. Continue, let's discuss the nursing responsibilities before, during, after the cranial nerve assessment. Before, first, collect and read the detailed history of the patient. Second, read the doctor's order stated you're giving the right assessment for the right patient. Third, prepare the materials needed for the assessment to save time and energy. Fourth, ask a consent from the client regarding with the examination so that she can be participative and aware about the assessment. Fifth, do medical hand washing to reduce contamination. Make sure that the client is at ease. Second, observe the client's physical and emotional reaction and response accordingly. Third, let the client identify the smell of cologne with each nose sweep separately with eyes closed. Fourth, provide adequate lighting and ask client to read from a reading material held at a distance of 36 cm. Fifth, observe the response of the illuminated pupil. Sixth, determine the sensation to warm and cold object by asking client to identify warmth and coldness. 7. Note ability to swallow. 8. Note for presence of gag reflex. 9. Assess the client's gait. So after, first, do the afterward, cleaning the area and throwing the things that was used during the assessment. Second, rate and always document the result. Note the abnormalities. Third, make sure that any significant other is informed regarding with the results.
That's the end of our report. We hope you learned a lot from it. Thank you and have a good day.